originally, moved to a new location in 2011, and we just finished an expansion and renovation of our existing space. Our mission is to respond to child abuse through a team approach designed to reduce trauma, seek justice, and provide hope and healing for children and their families. So how things used to be set up was that, let's say this little girl discloses at school, tells her teacher her mom's boyfriend has been hurting her. It used to be that the teacher would then go talk to the principal would tell the nurse, the little girl would have to talk to the principal, also have to talk to the nurse, and she'd probably do an exam. Then they'd call the police, and he'd want to know what was going on, so she would have to talk to him. He'd take her to the hospital, or another nurse, probably a social worker and a doctor, would talk to her and do other exams. Then the police would get the specialized detective involved. He'd probably take her to the police station, interview her again. She'd then have to talk to a DHHS worker. Then she'd need to talk to an attorney, and then probably have to go to counseling. So by now she's talked to 17 people. And imagine the worst experience of your life, probably the most terrifying experience of your life, and telling that to 17 strangers over and over. So now with this new model, well, fairly new, if Kate tells her teacher that she's being hurt by mom's boyfriend, teacher makes a hotline report, which then initiates an officer coming to the school, let's say, usually in plain clothes, and not scary looking or intimidating, typically brings her in an unmarked car to the CAC, where she can kind of play with all of our toys, very child-friendly place, while the team meets. She'll have an interview with the trained interviewer, get an exam, and then mom and Kate are referred to counseling. So really, we're part of the investigative process and we collaborate with law enforcement, county attorneys, and DHHS to increase successful prosecution, reduce trauma to the victims by interviewing them one time, and strengthening families by providing them with safety plans, resources, and referrals to counseling. We currently see an average of 1,300 children annually. And we, like I said, with that new expansion, we are now co-located with LPD's SVU. We've expanded to 3 medical exam rooms. We have 2 nurse practitioners full-time. We expanded our mental health services. We have space for 5 therapists down in our basement. We have a triage space for children being placed into foster care. And we've expanded training to include a new training space and added staff. So this was just last year, and the numbers have increased this year so far. But some pretty remarkable numbers. 1,278 kids served last year, just here. 76% of the kids are seen or suspected of having been sexually abused. 65% of the children seen are under the age of 12. So we provide here at the Child Advocacy Center immediate and ongoing support to the child and to the non-offending family members. We provide resources and referrals to counseling, like I stated earlier. We provide support throughout the criminal court process. We have 6 full-time child advocates, and they play a critical role in providing immediate and ongoing support to the child and their non-offending family members, mostly by listening to their needs and providing resource information. This is including referrals to trauma-informed counseling services. Most of our families are just beginning to deal with the issue that brought them to us, and many are struggling with additional issues such as financial challenges, mental health issues, substance abuse, and domestic violence. Our advocates are really the one face that connects the very complicated criminal justice system and helps the family navigate this system each step of the way. The advocates are involved throughout the investigation and prosecution of the case. If the case goes to trial, then the advocates accompany the child to the meetings with the prosecuting attorney, depositions, and if the kid has to testify. Our advocates provide court school, and that helps explain the criminal court process and system in a language that a child might understand better. the child is able to understand that not only the important role of telling the truth, but also the important roles of all the other people that they'll see and meet in the courtroom. If the accused is found guilty, the advocate provides assistance with the victim impact statement, which is provided to the judge at the time of sentencing. All right. Next, after meeting the advocates at the CAC, children will receive forensic interviews. And this is outlined in the statute that a forensic interview is to be arranged when there's allegations of sexual abuse, physical abuse or neglect, children witnessing a violent crime, if they're found in a drug-endangered environment, or if they've been recovered from a kidnapping, have been missing from care, or concerns of trafficking. We have trained forensic interviewers, and we interview typically kids from the ages of 3 to 18, 3 because that's when they can talk and participate. And then we do have the capability of interviewing adults with developmental delays. It's a very child-friendly environment that's designed to help the victims feel comfortable and safe. Each room is set up to accommodate one child and one forensic interviewer. Again, highly trained professional who specializes in talking to kids. While the interviewer is talking with the child, law enforcement and/or DHHS is in our viewing room watching the interview live. This helps to make sure they get the information they need for the investigation without needing the child to tell their story to them again. Children may participate in one interview and be done. Some take multiple interviews or extended interviews, and this might be due to developmental delays, an extensive history of abuse, or any additional disclosures that a child is ready to make after their initial disclosure. And we also do foreign language interviews. So for medical exams here, exams are provided by 2 nurse practitioners full-time. We have 1 registered nurse, and we do have 1 pediatrician that helps. All have advanced training. And then we also are able to provide medical consults, which is typically questions from law enforcement, some other providers throughout the community, and DHHS. We do those exams here at the CAC in Lincoln, and then we're also going to have the capability soon to provide exams at our satellite facility in York. Like I said, our advanced training is specific to pediatrics in general, and then the medical evaluation of the physically and sexually abused child. We're able to provide just specialized knowledge and experience in that area. So again, our exams, we can do any age 0 to 18, and then delayed adults. You know, we do sexual abuse exams, physical abuse exams, exams on children who are suspected of being pretty severely neglected, some follow-up exams that are warranted after an acute exam, either here or at the hospital. If injuries are noted on an initial exam, a follow-up exam is recommended in 2 weeks. And then we do follow-up STI testing, tests of cure, and just do follow-up exams to answer questions or concerns about a child's body or health that they might come up with after we've seen them initially. We do also provide hair testing for children in drug-endangered environments. Hair tests measure exposure to 5 illegal chemicals over the past 90 days. And about half of the tests come back positive for exposure to meth, marijuana, or cocaine. We also do foster care injury exams for kids who've been recently or acutely placed into the Nebraska State foster care system. And then trafficking is a unique and especially dangerous form of abuse. So these next couple of slides get a little bit wordy, excuse me, but it's really important. So trafficking is the use of force, fraud, or coercion to recruit, harbor, transport, provide, or obtain a person for labor or commercial sex acts. If this victim is a minor, consent is irrelevant. So if the child is 16 and is age of consent, if it's in the realm of trafficking, it doesn't matter. If the minor victim, say the 16-year-old, consented, the suspect can still be convicted. Knowledge of the victim's age is irrelevant, and law does not require force, fraud, or coercion. Labor trafficking of a minor is the knowingly recruiting, enticing, harboring, transporting, providing, or obtaining by any means, or attempting to do any of the above, intending or knowing that the minor will be subjected to forced labor or services. Sex trafficking of a minor, knowingly recruiting, enticing, harboring, transporting, providing, soliciting, or obtaining by any means, or attempting to do any of the above, to recruit, entice, harbor, transport, provide, solicit, or obtain by any means a minor for the purpose of having that such minor engage in commercial sexual activity, any sexually explicit performance, or the production of pornography, or to cause or attempt to cause minor to engage in commercial sexual activity, sexually explicit performance, or the production of pornography in exchange for anything of value. Anything of value. So in our community, communication often begins online. Sometimes pictures and videos are exchanged, social media messages are exchanged, and sometimes it's fairly innocent as far as the kid knows in the beginning. And then the perpetrators kind of reel them in, and then it gets pretty sticky. At BraveBe, we have a dedicated anti-trafficking program and team. Their work is very specific to the unique needs of trafficking victims and youths that are at high risk for becoming victims of trafficking. They work closely with law enforcement to identify, monitor, and support these kids. Medically speaking, we meet the youth where they're at and address any immediate health needs. What are their needs today? What education is appropriate today? Beyond addressing immediate needs, these specific exams serve to establish a trusting, non-judgmental, positive relationship for these kids. Often we see victims of trafficking multiple times before they're able to feel safe and comfortable disclosing their abuse. Just some risk factors for trafficking: history of trauma, which could be any trauma, any amount; involvement in the juvenile justice or child welfare systems; homelessness, being missing from care; LGBTQ+, substance use; lack of supported adults; family troubles; developmental or physical disabilities, gang activity, and just a lack of resources and basic needs. So these are some signs that we can, watch out for and recognize. Spending time where exploitation is known to occur is also another kind of red flag. If a child references traveling to other cities and states while they've been missing from care, that is concerning for trafficking. If a child that you see, is in possession of material items or cash that's not consistent with their access to these items, a super nice phone, multiple phones, clothes, the newest shoes, nails, hair, lash extensions, any of that stuff. If a child avoids answering questions or lets others speak for them, and also if they appear frightened, but most times they can appear annoyed, resistant, and a little belligerent to authority figures. So our medical exams here, for all of the abuse that we kind of discussed above, we do a complete head-to-toe exam. We don't force a genital exam, and when genital exams are performed, they're not invasive or traumatic in any way. Speculum exams happen occasionally, but only in adolescents, never in prepubescent kids. We do lab testing for STIs via urine, swabs, and then blood. We test for gonorrhea, chlamydia, hepatitis, syphilis, HIV, and trich. We do have a specialized camera system called a Cortex Flow. It's used for sexual abuse and physical abuse exams. Magnifies the genital area very well. Other body surfaces too, for bruises and injuries. And we're able to obtain high density digital images and videos. So it's not uncommon for anxious guardians to immediately go to the hospital or their primary care doctor for evaluation when concerns of abuse arise. We have a new collaborative effort between the Lincoln Hospitals and BraveBe to ensure proper SANE protocols are followed in the best interest of the patients and best practice. We've done some training with LPD, road patrol, hospital EDs, and SANE staff. We are, taking acute cases on weekdays during business hours. At this time, we don't have after-hours medical services, but we do have 24/7 consult availability with our staff to determine when and where to do the exam. So again, it's in the best interest of the child. Typically not needed to be done in the middle of the night. When a 4-year-old is up at 3 a.m., you're not going to get a very good exam. Also, is it going to be best practice for the child to have a forensic interview first before the exam? This protocol provides clear direction for the emergency department staff. And then we also provide a 1-page handout for caregivers for what to do in the meantime. No baths, minimal wiping, don't change clothes. And that's able to help us maintain any evidence as best we can. If you're interested in a copy of this protocol, I can get one for you. You can just contact me. Okay, so why do we do exams? Obviously to recognize injuries, identify any abnormalities in the anogenital region, to detect sexually transmitted infections. We provide prophylactic medication for STIs when necessary. We do pregnancy testing. We can see injuries outside of the anogenital area. We recognize self-harm injuries and then obviously to collect evidence when needed. But really the purpose of these exams is for diagnosis and treatment, not for investigating and prosecution of abuse. We spend a lot of time answering questions about bodies. Kids have worries and concerns. We had a 9-year-old who had been abused and was just terrified she was pregnant. We had a teenage girl thinking the reason she had large breasts is because she was sexually abused. Recently, a teenage male was concerned that the sexual abuse he suffered would affect the growth of his penis. We also had teen boys thinking that abuse they endured would make him gay. There's a lot of myths out in the community that we are able to correct. One being when a child is sexually assaulted by an adult, there should be injuries, which is not true. Actually, 95% of genital exams in known cases of trauma are completely normal. Sometimes parents are worried that their child's hole is bigger than normal or bigger than they think it should be, so they're worried the child's been sexually abused. Again, not true. Vaginal opening sizes vary from child to child, and it's not an indicator of sexual abuse. We do have some parents that want an exam to determine if their child is still a virgin. And this is not able to be done. There are absolutely no anatomy changes to a vagina or hymen after penetration. And so there's no way to tell if someone has had sexual intercourse or not. Really quite often, patients will disclose to us or disclose more medical staff due to the nature of our role. Sometimes they think we can see things, and then they know that we can address any concerns or questions they have, so they kind of feel more comfortable in the medical setting. Reassurance and education are the biggest reasons we do our exams. It's important to remember that we don't know how the abuse has affected this child, and reassuring them that their body's healthy and normal is so important. And the relief we see off of their shoulders, literally, when we tell them that nobody's ever going to know that this happened by just looking at them, you can visually see the weight come off their shoulders. So again, our exams assist law enforcement and DHHS as well. We collect evidence in cases of acute sexual assault. We do take photos, again, with our Cortex Flow camera. We know specialized techniques for good, usable photos, proper orientation. We take a close-up photo and then another photo with a measuring tool. So really at each site of injury, we have 3 pictures. As far as injuries go, it's kind of interesting. There's a lot of thought out there that depending on a bruise's color, you can tell how old it is. And bruises actually cannot be dated. This is due to many varying factors, including genetics, location of the injury, the amount of force used, the object used, and things like that. Bruises are uncommon in children less than 6 months old. If they don't cruise, they don't bruise. You know, bruises based on kind of development and age, bruises in certain locations, the history of how injuries happened, and then patterns that we are able to see are key characteristics differentiating accidental and inflicted injury. And then our exams are, I guess, beneficial because we do have medical hearsay. Our exams, the details, any additional disclosures, corroboration to the forensic interview helps. And it also in court, due to the medical hearsay, the forensic interview is able to be admissible. So a trained provider is really important to do these exams. Studies have shown that pediatricians and primary care providers and ED providers haven't been properly trained to examine the genitals of children. They lack general education on more specific anatomic structures in that region. They lack knowledge on exam techniques and interpreting findings. Sometimes there's improper testing techniques. And if there is an abnormal finding, they would need a trained provider in abuse to review those findings. You know, in terms of a proper exam, findings and interpretations on a child can vary widely in that same child, depending on who does the exam and how they do it. We know certain techniques based on age of a child and, you know, what their bodies need specifically, and then in terms of timing, correct timing for testing for STIs and things like that. Some examples of some unfortunate, you know, occurrences that happened with providers who are in their own right very educated and I'm sure good at what they do, but just not specialized in what we do. A dermatologist stated that genital warts are only from sexual abuse, which that's not true. There was a primary care doctor who told a teen a little too late when she asked if she was still a virgin. Very insensitive and not trauma informed. And again, no physical change happens with penetration, so virginity is not a physical characteristic of anyone. A gynecologist stated a child's hymen was, quote, obliterated, when in reality it was perfectly normal. Conversely, documentation from an ED physician described a hymen as intact and ruled out abuse. Well, they're always intact. So that, you know, the fact that something's normal isn't, doesn't rule out abuse. Again, 95% of exams are normal, and no injury does not mean no abuse. So one study showed that 70% of cases that were diagnosed as indicative of sexual abuse by ER physicians were found to be normal exams by child abuse doctors. Again, we have proper exam techniques, traction, proper positioning, and a trained provider is key to these accurate exam findings. Also, 30.6% of physicians felt comfortable rendering a definitive opinion about sexual abuse. That's not very high. And only 25% felt competent to testify in a legal proceeding about child abuse. We, as trained providers, have the ability to testify in court as both fact and expert witnesses. Okay, so for primary care and emergency department, things to do. Definitely you can reach out to BraveBe with any questions or concerns at any time. If you have questions about, you know, symptoms that are concerning for sexual abuse, sometimes kids come in with red or irritated genital or anal areas. Sometimes painful urination and UTIs make people concerned of abuse. Vaginal and anal bleeding, sometimes blood seen in diapers and underwear or on toilet paper is a little frightening at times. And then genital warts and herpes, those usually get very flagged for sexual abuse by community providers. They are concerning, but they are not diagnostic of sexual abuse. It's good for you guys to do a brief exam to rule out any injury requiring immediate medical intervention. Is the child bleeding profusely? Is there something that needs, you know, immediate surgical intervention? It's okay to look, but you don't have to do a complete exam. It's important to refer a child to us as soon as possible. Timing is crucial in cases of acute assault. In the case of sexual assault, any injury typically resolves very quickly due to just the very vascular tissue in those body areas. And then evidence collection is, you know, very time sensitive, so that's important. Okay, I lost track of where I was, I'm sorry. Sorry. Okay, there we go. Yeah, refer to us as soon as possible. And then, you know, along with the sexual abuse injuries, physical abuse injuries also change and disappear rapidly. So it's just important for us to lay eyes on the child quickly. And then the best thing to do if you're concerned is make a report. What you should not do, do not send patients directly here or to the hospital. Never force a genital exam. Do not use a speculum for prepubescent patients. Never touch the hymen with swabs or objects. It's very painful. You know, a hotline report first is the best way to get the ball rolling in the right direction, so we can offer each child and family just the proper services in the proper order to achieve the best outcome. And it's okay, you know, it's okay to not give an impression if you're unsure. It's okay not to know what something is or isn't and refer for specialized opinion. I mean, obviously this happens all the time in medicine. We refer to specialists, so don't guess or assume, just make the referral. And then again, to preserve any evidence, it's just important to limit contact and don't clean the patient off. Sometimes we've had cases where kids literally get blood wiped off their genitals so a provider can get a better look, or to do a straight cath for a UA. And it's just, you know, that could wipe away evidence. So just don't do it. So when it comes to reporting, minimal facts is really good information to collect, and you don't need more than that. This information in these, you know, 5 questions helps determine the next steps, whether something, you know, and how the DHHS staff codes the response. The what is where on a body was the child touched, and the child's disclosure. In their words, not your impression of what happened. So when you ask them what happened, if somebody says, you know, uses a different word for their vagina or their penis, use their words, and don't, again, assume anything. When you're asking about when, immediate medical attention might be necessary. And also the timing helps the investigators know the priority. Where helps establish jurisdiction, so they know what, you know, which law enforcement needs to be involved. Who, is it an adult that's done the touching? Is it a child? That's important. And then when is the next time you'll see them? You know, this determines the access of the child to the alleged perpetrator. Is the alleged perpetrator in the home? Are they a relative they see only on holidays? You know, it's just important to determine safety. You don't need to ask anymore. Obviously, we don't want the child to be questioned or to talk in detail about their abuse at this time. You know, that'll come later when they're here. And typically any report that comes from a provider will be screened as a P1, like priority 1, high priority. So that's good to know as well. You can call law enforcement in, you know, with immediate concerns. Otherwise, calling the hotline is the way to go. Nebraska state law requires that any person who believes a child has been or is being abused or neglected make a report. And then also consider the requirements of your professional license as well. We as providers are mandatory reporters, and it's always okay to maybe over-report and be wrong, than not report and be wrong on that end. They do use a structured decision making protocol to determine if they're going to accept the case or not, how it gets accepted, which caseworkers assigned, and how the ball continues to roll from there. And they're the ones that can help you know what to do regarding the child's safety. They'll let you know next steps and kind of keep you in the loop that way. So BraveBe, we have the comprehensive services for families and children of suspected abuse and neglect. We provide the advocacy, the forensic interview, medical services, on-site therapy. We have private practice therapists, Lutheran Family Services, and Project Safe through UNL. We provide case coordination and training and prevention for sexual abuse, physical abuse, neglect, trafficking, things like that. We use this collaborative multidisciplinary approach designed to reduce trauma, seek justice, and provide hope and healing for these children and their families. These kids are so brave, and we do this work so they can be. So as we close out Child Abuse Awareness Month, on behalf of BraveBe, I'd like to thank CHI for this opportunity to share more about what we do and how we serve the children affected by abuse and neglect. We appreciate your partnership and support.
Thank you, Jessica, for providing this presentation.